ISA National. Welcome, madam. And our special invitee, Praveen Vanu, madam. Welcome, madam. And she is also president of the West Bengal ISA. And it is my pleasure to welcome Dr. Priyanka Srivastava, Dr. Upallapati, and Dr. Gautam Saha as a moderator. Hello, Dr. Sharad.
Yes, sir. Thank you, sir. Thank you very much, sir, for inviting all the speakers and the guests. So we will start in next 2 minutes.
Yes, please. You start now. Our session.
Thank you, sir.
Dr. D.K. Singh, sir, good evening.
Good evening, sir. Good evening.
Sir.
Good evening.
Yes, yeah, good evening, everyone. So thank you, everyone. So we are going to start the session. Yeah, I request our President, Dr. Venkat Giri, sir, to please say a few words, and then we will, Dr. Venkat Giri, sir.
Good evening, President and Secretary of ISA. We have the GC member, Dr. Ekadas, President ISA West Bengal, Praveen Baru, all executive members, academicians, and today's faculties. Once again, namaste. I'm very happy to participate in this. I think it is second or third time I'm participating in your CMEs.
Yes, sir. Yes, sir.
And we have this doing excellent. Last year we were second. First, I think second. You are this year also leading with the good academic activities and hosted by different branches. And the topics are also very nice, used for both PGs and practicing anesthetists. We people can sit at our home and enjoy the topics prepared by the different faculties, and all PGs and permanent anesthetists can get benefit of these topics. And that may be a blessing in disguise that with this technology, we are able to hear and update our knowledge, because we may not have attended this much CMEs if you go to the physical meeting, because PGs and others will be chit-chatting outside. Anyway, I wish once again all the best, and thank everybody, especially Sharad, for his very active and enthusiastic activities, and every time he remembers, and just he reminded me, Venkatagiri sir, and I was thinking there is some program today. What is that program? Tomorrow, yes, there is Borivali program. Today I was thinking there is some program I was missing. Good that Sharad reminded me and made that. Thank you, DK. It is nice seeing again after a long time. Thank you, and Parveen also. After a long time we are meeting. Okay. All the best. Thank you.
Thank you. Thank you very much for your kind words. Now I invite our GC member, Dr. Rekha Das, madam, to say a few words. Rekha Das, madam, please unmute yourself.
Yes. Thank you, Dr. Sharad. A very good evening to all. To our chief guest, Dr. Venkat Giri sir, our national president, and Dr. Praveen, the president of ISA West Bengal, and Dr. D.K. Singh, whom I'm meeting after a long time on this podium. So thank you very much for the opportunity. And Dr. Sharad, who has been a very academic person throughout the COVID. I've seen him organizing such wonderful webinars and been on this forum last for a CPR, and again this is the second opportunity. I'm very happy that he has taken Bihar Jharkhand so much ahead in academics. And so I wish all the speakers very good luck, and we can now start off. I think with these kind words, I would like to hand over the podium to Dr. Sharad. Dr. Sharad, please.
Thank you, madam. Thank you very much. Our special guest of the day, Dr. Praveen Vanu, madam. This is the first time we are interacting with you. So we like to hear you also, Dr. Praveen Vanu, madam.
Good evening, everybody. I am really feeling very happy and delighted that Dr. Sharad Kumar, he had given me this opportunity. This is the chance that I can see you. I am seeing Venkat Giri sir after so many days, and Dinesh and Manoj. I can't find him till now, and all other speakers. So I wish all the speakers very good luck. And now, thank you once again. Now the podium is for the, I think it's for the speaker now.
Thank you very much. So without wasting any time, now we are going to start the session. So I request our madam, Dr. Praveen Vanu and Dr. Rekha Das madam to please conduct these two sessions. Then we will have the moderator Gautam Saha sir to have the pro and con session. So I request Dr. Rekha Das madam to please be the moderator of this first session and the Praveen Vanu and Praveen Vanu madam the second. So it will be our privilege to have you on the podium. Thank you, Rekha madam. Please start the session.
With this kind words, I would like to welcome Dr. Priyanka Srivastava, who is the Assistant Professor of the Department of Anesthesiology from the Rajendra Institute of Medical Science, Ranchi. And it's a very interesting topic, how I am going to prepare my patient for awake fiber optic bronchoscopy. Let us hear from her. Dr. Priyanka, please.
Good evening, ma'am. Good evening, everyone. Let's start.
Your voice is...
Hello, am I audible?
Yes, yes, yes. Now, once you carry on, we will know how clear it is.
Yes, yes.
You are audible, madam. Please go ahead.
Yes, to start with the topic, when to perform awake fiber optic intubation or awake intubation. We perform awake intubation if the patient is suspected to be a difficult intubation and when one or more of the following apply. Either difficult ventilation or increased risk of aspiration, or the patient is likely incapable of tolerating a brief apneic episode, or there is expected difficulty with emergency invasive airway rescue. Any one factor alone, that is assessed difficulty with ventilation or intubation or increased risk of aspiration or desaturation, may be of sufficient clinical evidence to warrant an awake intubation. Awake intubation is planned in cases of anticipated difficult airway. Some predictors of difficult airway are patients with head and neck pathology, including malignancy, previous radiotherapy, reduced mouth opening, limited neck extension, obstructive sleep apnea, morbid obesity, or progressive airway compromise. Relative contraindications for awake fiber optic intubation are local anesthetic allergy, airway bleeding, or uncooperative patient. Only absolute contraindication is patient refusal. This is the algorithm of ASA difficult airway. Today, we'll focus on the part dealing with awake fiber optic intubation. It also says that if the patient has suspected difficult laryngoscopy, and if any one of these factors is present, that is either difficult face mask ventilation or risk of aspiration, or there are chances of rapid desaturation, or there is suspected difficult emergency invasive airway approach, then we can always plan for awake fiber optic intubation. Now, the pre-anesthetic evaluation. Awake fiber optic intubation will proceed more easily in a well-informed, cooperative patient who understands the procedure. Specific instructions such as not to speak during the procedure, raise hand when want to speak anything, thorough anesthetic history and physical examination, history of allergy to local anesthetic, written informed consent, history, examination, and appropriate investigations. The procedural setup. Awake tracheal intubation can be associated with the greatest operator-related physical, mental, and psychological stress of all elective airway management interventions. Teamwork, good communication, and appropriate preparation may mitigate these challenges, and the importance of well-trained, competent assistants should not be underestimated. It is recommended that ECG, non-invasive blood pressure monitoring, pulse oximetry, continuous end-tidal carbon dioxide monitoring are used throughout the procedure of awake tracheal intubation. Workspace ergonomics have an impact on performance and safety and considered before starting the procedure. This includes optimizing the position of patient, operator, and assistant as location of equipment and monitors, which should be in direct line of vision of the operator. This is an image which shows the Ergonomics. The image A, and there are two images, image A and image B. Image A is for the patient in whom we are planning for awake tracheal intubation in sitting or a semi-sitting position. We can see that the operator is by the side of the patient and the video monitor is in the line of sight of the operator. The image B is for the patient whom we are planning to do awake fiber optic intubation in supine position. Here the operator is at the head end and the video or the monitor is towards the rear end of the patient, but in line of vision of the operator, and the assistant is nearby the operator. Complications or unsuccessful awake tracheal intubation, although uncommon, should be prepared for, and immediate access to emergency drugs and equipment is essential. A plan for unsuccessful awake tracheal intubation, including possible postponement, front of neck access, or high-risk general anesthesia, should be discussed explicitly and agreed on by all team members before beginning the procedure. Select an appropriate route for intubation. The route for tracheal intubation should take into account patient anatomy and surgical access. For example, in patients with limited mouth opening, the nasal approach may be the only option, while in patients having nasal surgery, the oral approach may be the preferred route. There is no evidence or consensus among experts demonstrating superiority of one route if both are feasible. Checklist is very important. The key components of awake tracheal intubation are sedation, topicalization, oxygenation, and performance. This is the Difficult Airway Society awake tracheal intubation technique. It consists of the same: oxygenation, topicalization, sedation, and performance. The administration of supplemental oxygen during awake tracheal intubation is recommended. This should be started on patient arrival for the procedure and continued throughout. If available, high flow nasal oxygen should be the technique of choice. Airway topicalization. The success of awake tracheal intubation depends on effective topical application of local anesthetic to the airway. Vasoconstriction of nasal passage reduces the incidence of epistaxis. The use of topical nasal vasoconstrictors before nasotracheal intubation is recommended. Lidocaine is the most commonly used local anesthetic agent for awake tracheal intubation. The dose of topical lidocaine should not exceed 9 mg per kg lean body weight. The use of cocaine for topicalization and vasoconstriction can be associated with toxic cardiovascular complication. While its analgesic efficacy during nasotracheal tube insertion is no better than cofenylcaine, which is a combination of lidocaine and phenylephrine. Phenylephrine causes vasoconstriction and lidocaine provides local anesthesia. Cocaine in this setting is therefore not advised, and phenylephrine in combination with lidocaine is more appropriate. Technique of topicalization: atomization, nebulization, or SAGO, or spray as you go technique. The technique of topicalization of the airway: atomization. The local anesthetic is delivered to the soft palate, nasal mucosa, or the posterior pharynx in the form of fine spray or mist of 30 to 100 micron particle size with devices known as atomizers. The LMA Magic mucosal atomization devices are examples of such devices. These are inexpensive, disposable, and latex-free devices. These are the images of some mucosal atomization devices. This is a magic airway to facilitate fibroscopic intubation, as well as atomization can be done to this airway. Nebulization: it helps in delivery of the local anesthetic to the airway. The technique is easy to use, and if done properly, it can very effectively anesthetize the upper airway. A face mask nebulizer can be used. Lignocaine in a dose of 4 ml of 4% solution is used for this purpose. This is a face mask nebulizer. Now for For topicalization of airway, 10% lignocaine spray is also used. And that spray is sprayed at the tonsillar pillar base of the tongue and in the nasopharynx. 30 to 40 sprays can be done. Now we come to the spray as you go technique. This technique is performed during the process of intubation through the fiber optic bronchoscope. Lignocaine in aliquots of 2 ml of 2% loaded in 5 ml syringe with 3 ml air is sprayed through a epidural catheter from the suction port of the fiber optic bronchoscope at the desired site. The drug is allowed to act for 30 to 60 seconds, after which the fiber optic bronchoscope is advanced further. Since the local anesthetic is applied just prior to intubation, the airway reflexes are protected till immediately before intubation. This is an image of a fiber optic bronchoscope, and we can see here the epidural catheter is inserted through the suction port, and it is used in the Sago technique. Now we come to the nerve supply of the airway, because in awake fiber optic intubation, we also give nerve blocks to the airway. The nasopharynx and the nose is supplied by the trigeminal nerve. The oropharynx is supplied by the glossopharyngeal nerve, and the trachea is supplied by the vagus nerve. Now, when we are planning for a nasal route for intubation, we have to block the trigeminal nerve. For that, Sphenopalatine ganglion block is done. We use cotton-tipped applicators soaked in 4% lignocaine with epinephrine, 1:2 lakh, are passed along the upper border of the middle turbinate at an angle of approximately 45 degrees to the hard palate and directed posteriorly until the upper posterior wall of the nasopharynx is reached. Now the anterior erythemoidal nerve block, a long cotton-tipped applicator soaked in 4% lignocaine with epinephrine 1:2 lakh is inserted parallel to the dorsal surface of the nose until it meets the anterior surface of cribriform plate, is left in place for approximately 5 to 10 minutes. Here in this image, it is very well seen that these two cotton-tipped applicators are there, and we have to note the direction in which these cotton-tipped applicators are advanced into the nasal cavity. For blocking the anterior erythemoidal nerve, the cotton-tipped applicator should be advanced parallel to the maxilla. And for blocking the sphenopalatine ganglion and nerves, the cotton-tipped applicator has to advance parallel to the dorsal surface of the nose. Now we come to the glossopharyngeal nerve block, which supplies the oropharynx. The patient is placed in a sitting position with mouth opened wide and tongue protruded. With the non-dominant hand, tongue is displaced medially. A 25-gauge spinal needle is inserted 0.25 to 0.5 centimeters deep at the base of the palatoglossal arch, just lateral to the base of the tongue, and an aspiration test is performed. 2 ml of 1 to 2% lignocaine is injected, and the procedure is repeated on the contralateral side. We can also block the glossopharyngeal nerve by xylocaine spray, 10% xylocaine spray. The glossopharyngeal nerve can be blocked by an extra oral route also. For this, imaginary line is drawn at the point connecting the mastoid process and the angle of mandible. And we just go with a spinal needle just perpendicular to the midpoint of this line. And when we get contact of the styloid process, then we walk over the styloid process downwards, and there we inject the 5 to 7 ml of 2% xylocaine. Now we come to the superior laryngeal nerve block. The patient is placed in supine position. The head is slightly extended. The hyoid bone is identified by deep palpation, and the greater cornu of hyoid is identified at the most lateral aspect of the bone. With the dominant hand, a 25 gauge needle is walked off the corner of the hyoid bone in an anterior-inferior direction. At a depth of 1 to 2 centimeters, a negative aspiration test for blood is performed and 2 to 3 ml of local anesthetic is injected as the needle is withdrawn. The block is repeated on the opposite side. This is the image showing the superior laryngeal nerve block. As we can see, the non-dominant hand is stabilizing the trachea and the hyoid bone, and with the dominant hand, injection is being given. Here, this image shows the nerves and the approach. Now coming to the Trans-Laryngeal Anesthesia. Patient is placed in supine position with neck in extension. The cricothyroid membrane is identified in the midline as a depression between the thyroid cartilage and the cricoid ring. Using a 25 gauge needle, a small skin wheel is raised. A 25 gauge IV cannula attached to a 5 to 10 ml syringe containing 3 to 5 ml of saline is used. The needle is advanced to the skin perpendicularly. After a pop, aspiration is performed to check for the presence of air. To confirm the placement in containing saline is removed and the catheter is left in place. Another syringe containing local anesthetic, 3 to 5 ml of 2 to 4% lignocaine, is attached, and after reconfirming the position in trachea, the drug is injected. This induces cough, which helps in spreading the local anesthetic in the trachea. This is an image which shows the transtracheal injection. This needle is piercing the cricothyroid membrane. For awake fiber optic intubation, anti-silagogue, there is limited evidence to support their use in awake tracheal intubation. But in anesthetized patient, the clarity of a visual field through a flexible bronchoscope may be improved. If used, intramuscular anti-silagogue should be injected 40 to 60 minutes before performing awake tracheal intubation for peak mucosal drying effect. Anti-silagogues such as glycopyrrolate, atropine, or hyoscine can be used, but most commonly used agent is glycopyrrolate in the dose of 0.2 to 0.4 milligrams and should be given 30 to 40 minutes before the procedure. Aspiration prophylaxis should be given. Administration of a non-particulate antacid, sodium citrate, 30 minutes prior to awake intubation increases the pH of gastric contents. Intravenous administration of H2 receptor blockers such as ranitidine and famotidine. Proton pump inhibitors, pantoprazole or omeprazole, are not as effective as histamine blockers because they may be used in patients on chronic. However, they may be used in patients on chronic H2 blocker therapy.
Was headed to hit her. Then mysteriously moved away.
Prokinetic agents such as metoclopramide can be used. Now we come to sedation. Awake tracheal intubation may be safely and effectively performed without sedation. However, its use during awake tracheal intubation can reduce patient anxiety and discomfort and increase procedural tolerance. Minimal sedation is recommended. Minimal sedation is defined as a drug-induced state during which the patient responds normally to verbal commands, whilst the airway, spontaneous ventilation, and cardiovascular functions are unaffected. Remifentanil and dexmedetomidine are associated with high level of patient satisfaction and low risk of oversedation and airway obstruction when used for awake tracheal intubation. As a sole sedative agent, propofol is associated with a greater risk of oversedation, coughing, and airway obstruction than remifentanil. Sedation should not be used as a substitute for inadequate airway topicalization. Drugs which can be used for sedation are in benzodiazepine. Midazolam can be used in the dose of 0.5 to 1 milligram IV. The onset is rapid and effect peaks within 2 to 3 minutes of IV administration. Opioids can be used. They provide analgesia, depress airway reflexes, prevent hyperventilation associated with pain and anxiety. Shorter acting agents like fentanyl and remifentanil have a rapid onset and relatively short duration of action. Dexmedetomidine, it has a sedative, analgesic, anxiolytic, antitussive, anti-silagogue effects while causing minimal respiratory impairment even at high doses. It can be given in the dose of 1 microgram per kg loading dose over 10 minutes, followed by a continuous infusion of 0.2 to 0.7 microgram per kg per hour. Now, 2-point check of tracheal tube placement. A 2-point check is therefore required to confirm the position of the tracheal tube. Visualization of the tracheal lumen with fiber bronchoscope and capnography to exclude esophageal intubation. Anesthesia should be induced only when the 2-point check has been confirmed and correct tracheal tube placement has been confirmed. Once the flexible bronchoscope is in trachea, the carina should be identified before advancing the tracheal tube to minimize the risk of misplacement. The number of attempts should be limited to 3, with 1 further attempt by a more experienced operator. So the attempt comes to be 3 + 1. These are some videos of awake fiber optic intubation, which I have included in my presentation. This is the patient. Now we can also see the ergonomics. The video is just in front of the operator. Now the trachea is visible. We advance the bronchoscope till, and then we railroad the endotracheal tube over the fiber optic bronchoscope. We can see the tracheal rings. Now we can see the carina. Now the endotracheal tube will be railroaded. This is one more video of awake fiber optic intubation. This is Naseem sir doing the fiber optic intubation. Thank you for the patient hearing. Thank you.
Thank you, Priyanka. That was an excellent and a comprehensive talk on how to go about with awake fiber optic bronchoscopy. I don't think there are any questions on the chat box. So I would just add a few words because we at our center regularly do this fiber optic bronchoscopy. So I've just add a little bit of experience from my side. One of which is sometimes it so happens that when you are having a difficult airway and you are giving little sedation to the patient, because sometimes it is deemed necessary to sedate your patient. Normally we do it with propofol or with fentanyl now in our setup. So what happens is that the muscles becomes very lax. The airway muscles becomes very lax, and the mucosa also budges in, and this causes a partial obstruction convert a partial obstruction into a total obstruction. So this has to be borne in mind while you are going for a fiber optic. How compromised is your airway, and whether you should at all sedate your patient or not. So sometimes sedation can actually make the muscles all very lax in a supine position, and they can make it airway totally closed. And this is a possibility that can be encountered by anyone. Second is sometimes there may be trauma and there might be bleeding, unanticipated bleeding during the procedure. So because of the congestion, because of the growth, huge growth inside the mouth, and also you need to be experienced and you must be alert that such kind of torrential bleed can occur during the procedure. So you need to be very well prepared for suctioning, and whether you should go ahead at all or you should stop for a while and then do a good airway suctioning before you go for a next step again, where you can go for a good vasoconstrictor, and then you can plan with a pediatric size of a bronchoscope rather than an adult size, where the trauma, the chances of causing a trauma is little less. And third thing, which in fact I encountered this today while I was doing a fiber optic bronchoscopy with a patient of mine with a CA tongue, a recurrent case of CA tongue who had been previously operated for CA tongue, and a SOND had been done, and there was a little disfigurement of the upper airway. So while I was doing, I noticed that the epiglottis was very floppy. So it was constantly coming in the way of negotiating the fiber optic bronchoscope. So in fact, it took me a long time. Then I suddenly realized that I needed to lift the jaw.
Yes.
So after I lifted the jaw, immediately the airway became open. But the fourth problem which I encountered with this patient was I could put in the bronchoscope, but a 7 size flexometallic tube I could not negotiate. This was the first time I experienced this. After so many years of practice, these are the things that can really happen. The tube would not go at all by any means. Even I applied little more phenylephrine. I went for everything I did. I put in a more little of lubricant also, but I could not negotiate the tube. And my surgeon was telling, madam, don't remove, try to do it, because it was already a difficult case of fiber optic intubation. It's going to be so I said, no, it is going to be easy. So I removed, I loaded it with a number 6 size, and I did it through the other nostril, and I just lifted the jaw, and this time it went straight. So little negotiation of the patient is sometimes necessary even for a fiber optic. We are thinking we are doing fiber optics, so we are doing with a flexible bronchoscope. It is not easy. It's going to be very easy, whatever the position of your patient is. But sometimes small maneuver of the patient also helps. So these are my few experience which I shared with you. And if anybody can share anything, and is there some question in the chat box? No. Okay, then. So with this, we come to the end of this topic. So we can go over to the next one. And I would like to, if Sharad gives me the permission, I would like to hand over the podium to Dr. Praveen. So she is going to take over from me.
Thank you, ma'am. Thank you very much. Just the house is open for the question answer. If anyone wants to ask any question, please come. Please raise your hand or ask directly. Hello.
Sharad.
Anyone?
Sharad,
Yes,
Dr. Nishant, you want to say something, please?
Am I audible?
Yes, sir. Am I audible? So there's nothing to ask, sir. There is a few things like what we do in our setup, like ma'am was also highlighting. First of all, the concept of continuous oxygen supplementation. We saw that in the talk also by Dr. Priyanka. She had kept that. So now what we do is, if at all there is any method, we put in HFNO on patients, and that solves a lot of problems. Just in case we are giving a little bit of sedation also. Like ma'am was saying, there have been case reports from our institute where we have added Dexmedetomidine to lignocaine nebulization, and that has shown to help us a little bit. And coming to that, sir, earlier what we used to think was the maximum dose of lignocaine is 7 milligram per kg. Now that we have increased it to 9, these are based on the these anesthesia guidelines. So now we go up to 9 milligram per kg. these are just some of the little additional information. If the other people also want to add something, sir.
Small comment from my side, Dr.
Yes,
Naseem.
Dr.
Yes, I did a few cases here. Simple awake intubation with little sedation. Dexmed infusion in perioperative room. I started 50 microgram in a 500 ml of bottle. At the end of half an hour, nasal blockage only with the xylocaine 4%, nasal spray used, and transtracheal injections. The transtracheal injections are quite effective. And I think one patient referred from Bokaro, which was a case of failed intubation there, twice or thrice. We did because of no neck movement. The indication was neck movement was absent.
Dr. Naseem,
yeah.
we are not able to hear your voice. Maybe some network issue.
Okay, no
Dr.
problem.
Praveen, you want to say something, please?
Yeah, actually, I just want to add one single point that the maximum allowable limit is 7 to 9 milligram per kg body weight. But as we are using liquid in so many different ways, like we are giving spray, we are giving nebulization, local infiltration, everything. Today only it happened in our upper roti that during difficult fiber optic intubation, this patient, he suffered a cardiac arrest. So we must be very careful about the total amount of lignocaine is given to the patient. That is today it happened in our OT only. Am I audible?
Yes, madam, you are audible, madam.
Yeah, that's the thing, because we are using like the blocking the nerve, that spraying and transtracheal, where every time we are using lignocaine. So the total amount is very important. How many milligrams? We must be very cautious about it.
That's a very valid point, madam. We should be aware about how much the dose, how much the total dose we are using during the procedures. So we have to have the record and keep that thing in our mind during the procedures. Sometimes with over enthusiastic, we push 1 ml, 2 ml, 3 ml nebulization. So total dose increases a lot. So this can cause problem. So is there any question?
I don't think there are any questions, no.
So we will move on to the next speaker, Dr. Vamsi. And for this session, I would like to invite Dr. Praveen Vano, madam, to be the moderator of the session. Madam, please start the session.
Please, Dr. Vamsi, you share your initial slide, because I don't know what.
Yeah. Just a second, madam. Just 1 minute. Just give me a minute. Madam, is my slide visible?
Yeah, and Dr. Vamsi, yeah, it's that my nose specific designation, whether you are a freelancer on any hospital, I don't know, but this is the difficult airway guideline 2022, where Indian guideline is also attributed very much. So I think it will be a very interesting session, and as an anesthesiologist, everyone should be very much acquainted that what significant changes are there, or must be very conversant about all the steps. So please carry on, Dr. Vamsi.
Just a second, madam. As you asked about his, he is Dr. Vamsi Krishna Uplapatti. His full name is. He is my colleague. He is in the Department of Anesthesiology, Tata Main Hospital, Jamshedpur, and he is a specialist. And
okay.
Thank you, ma'am. And I request Dr. Vamsi to please start the session.
Yes.
Yeah. The practice of the airway, and the anesthesiologists who were administering anesthesia were not hands-free, despite of the development of various harnesses and adequate record keeping would have been very tough. And however, endotracheal intubation was associated with so much of mortality, morbidity, which made it unsafe for daycare procedures during that regime. So in the year 1981, Sarachi Brain developed airway management device that was less stressful for the patient, avoiding unwanted complications of general anesthesia and multiple laryngoscopies. So this device even addressed the problems of various difficult mask ventilation, thus giving our anesthesiologists a safer alternative to complex intubation scenarios, specifically in emergency. So even in 2022, we are celebrating 30 years of development of LMA. This device, even till date, holds top priority in the management of anticipated difficult airway. Good evening, one and all. I'm Dr. Vamsi Upalpati, and I'm a specialist anesthesiologist in Tata Main Hospital. So today's agenda, I'm going to go with this format. First, the definition of difficult airway, the ASA 2022 guidelines, and I'm going to give a little emphasis on DAS guidelines, the Difficult Airway Society guidelines, the standard recommendation, the case scenarios, and a visual simulation and a practical approach to various difficult airway scenarios, the difficult airway card, the take-home message, and the questionnaire. So when we come to the definition of difficult airway, the difficult airway is defined as a clinical situation in which a conventionally trained anesthesiologist experiences difficulty with mask ventilation or difficulty with laryngoscopy and endotracheal intubation are both scenarios. Coming to the ASA algorithm, first ever, the ASA task force formulated the difficult airway pathway in the year 1993, which was subsequently developed with many additions and modifications in the year 2003. In 2013, there were some other additions, and currently in the year 2021, October 2021, they came up with an updated ASA difficult algorithm. So this is a brief view of the 2013 guidelines, which most of you are aware. So with the paucity of the time, I'm not emphasizing much on this 2013 guidelines. And this is the 2022 guidelines, which is the most updated version. And this was formulated in the year 2021, October. So in this, if you focus on this slide, so this is the airway difficult algorithm. This is the series of questions. Difficult ventilation with face mask or a supraglottic airway device. Significant risk of aspiration. Not necessarily, intubation is not only done in the OR in a controlled environment. We as an anesthesiologist were called to manage an airway scenario in wards, in emergency, in pediatric areas, and in remote location. So is there any significant risk of aspiration? Because not necessarily every patient is fasting. Is there increased risk of rapid desaturation and suspected emergency invasive airway? If your question's answer is yes, then the ideal way to intubate is intubation attempt with patient awake. Awake intubation, if this is successful, yes, we are in the safe zone. If this fails, let's say the intubation patients with intubation patient awake, the patient failed, consider other options. As our colleague, Dr. Priyanka Srivastava discussed about awake fiber optic intubation at stretch, I'm not focusing on the in-depth of the awake fiber optic intubation. And she gave the guidelines of 3+1 intubation. If you fail in either of the 3+1, and that is the 4 attempts, then postpone the case. And all throughout the procedure, we need to optimize the patient we need to optimize and we need to give adequate oxygen throughout, which I will be discussing in my subsequent slides. So the first initial attempt would be attempt at intubation in an awake patient. However, intubation after induction of general anesthesia, this comes in this way. If this fails, so you have to, this is the recent, in the recent guideline, this is the new update which was given. You have to limit the attempts. In this, once you limit the attempts, you call for help and arrange for other logistic things for securing the airway, either through an emergency surgical airway. So are you able, at this point, you question yourself, are you able to mask ventilate the patient adequately? Are you able to do a bag and mask ventilation? Is there is a good chest rise? Is there is a good ETCO2? Is the patient hemodynamically stable? If the answer is yes, then you have this, then you go for a non-emergency pathway. If the answer is no, the mask ventilation is not adequate, you consider inserting an oral airway or a nasal airway and try to ventilate. If this attempt is not fruitful, then you consider inserting a supraglottic airway. So even in 2022, as discussed in my previous slide, supraglottic airway device still carries the utmost importance in any difficult airway scenario. If the supraglottic airway ventilation is adequate, you're in a safe zone. And again, you limit the attempts and consider awaken the patient. Don't ever paralyze the patient unless and until you confirm that you have a good chest rise and you have a good ETCO2 trace. So in this scenario, if you're not able to ventilate the patient, even with an oral airway or a nasal airway or a supraglottic airway, then you have to consider this emergency pathway. Always, all throughout the procedure, these things highlighted in the red zone: optimize the oxygen throughout, limit attempts and consider awakening the patient, and limit attempts and beware of the passage of the call for help for invasive access. These are all the new additions in the 2021 guideline. Let's say you land up here and you are not able to mask ventilate the patient, and you're not able to ventilate the patient with an airway or a supraglottic airway device, then you are an emergency pathway. Limit the attempts and be aware of the passage of the time, and always call for help and pull up your logistic issues to secure the airway through a supraglottic airway device or through emergency surgical access. A small emphasis on the difficult airway society. Though the ASA guidelines look little complicated, the ASA algorithm looks little complicated, DAS guidelines, the Difficult Airway Society guidelines, which were formulated by the UK, this looks more simple. In this, we have 4 plans: Plan A, Plan B, Plan C, and Plan D. Plan A is very simple: the face mask ventilation and tracheal intubation. In this, if the laryngoscopy is successful, then you have go ahead with tracheal intubation. In case in the plan, if you fail in the Plan A, that's the failed intubation, then comes your Plan B. Either you maintain the oxygenation throughout the patient with an oral airway or a supraglottic airway device. If the supraglottic airway is device, you could secure the airway, the supraglottic airway, then you're successful in the attempt. At this point, you stop one thing: either you wake up the patient or intubate the patient with a supraglottic airway device like intubating LMA or any other advanced device. In case in case you feel that the procedure is a short going procedure and there's no risk of aspiration, then you may proceed without intubating the trachea. And at this point of time, in case you feel that at one point of time, this gives you a leverage. So you may consider attempting a tracheostomy or securing the airway with a cricothyroidotomy or any other surgical way. Plan C. This is a face mask ventilation. This is the in case you fail in this spot also, try ventilating the patient via mask ventilation with the oral airway device. And if you succeed, you use 2-hand technique, ask for call for help. If you succeed, wake up the patient. In case you fail even this attempt, laryngoscope, you fail in a supraglottic airway device, you fail ventilating the patient even with the oral device, and even if you fail with 2-hand technique, then you call for Plan D, which is emergency cricothyroidotomy. So the standard recommendation says one is anticipated difficult airway, the second one is unanticipated emergency difficult airway, and extubation of a difficult airway. However, I'm going to focus only on anticipated difficult airway and unanticipated difficult airway. So the standard recommendation for a anticipated difficult airway, you always consider awake intubation, the patient who can be adequately ventilated, but they cannot be intubated. When you plan this kind of scenario, this is an anticipated difficult airway scenario. Not be ventilated or intubated, and difficulty with emergency airway. These all patients stand in the category of anticipated difficult airways. Postbone contracture, a patient coming for peritonsillar abscess or quinsy, patient with CA buccal mucosa with severe trismus. All these scenarios come in anticipated difficult airway with limited mouth opening, where you can't pass this even an oral airway or a supraglottic airway device. In my subsequent slides, I'm going to show the very good photographs and real time how we manage such kind of cases. So before attempting any kind of intubation of anticipated difficult airway, be aware that you need to do in a time frame. Be aware of the passage of time, and always keep a check on number of attempts you are doing, and limit the number of attempts of tracheal intubation and supraglottic airway device. So this is about the anticipated difficult airway. Coming to the standard recommendation of unanticipated or emergency difficult airway, always whenever you land up in an emergency difficult airway, always first call for help and determine the benefits of awakening the patients or restoring the spontaneous breathing. Never ever paralyze the patient unless and until you have a good adequate ventilation, good EtCO2 trace and a good chest rise and the patient is hemodynamically stable. So if a difficulty is encountered with individual techniques, you can use either combined techniques like invasive or non-invasive techniques. And so always keep a check on the time and the number of attempts you are using to secure the airway in unanticipated difficult airway. And always involve a senior because experience is this thing. So if you focus on this slide, for intubating, you need to align the oral, pharyngeal and laryngeal accesses in one plane. So in any given scenario, either when you are ventilating the patient through a bag and mask ventilation, or when you are doing a laryngoscopy and securing the tube and intubating the patient with a neotracheal tube, you need to align the oral, pharyngeal and laryngeal access in one plane. So this is the difficult airway cart. So in the difficult airway cart, in our difficult airway cart, these are all the devices we have, all size iGels, various size of laryngeal mask airways, the intubating LMA Supreme, LMA Supreme, ProSeal LMA, and iGels. So these are the advanced difficult airway cart, all size oral size airways, the boogie, the fiber optic bronchoscope, the king size video laryngoscope, and the video laryngoscope. So this is a combi tube. This comes to handy when you land up in a difficult airway scenario, where you land up in a CVCA scenario, or where you need some time frame for this thing. So difficult mask ventilation. If you focus this image, this patient is a 55-year-old male coming for a CA buccal mucosa surgery. If you see, his mouth opening is almost zero, and he is in severe trismus, and this is a very prolonged surgery. Fortunately, his nasal cavity are intact. So this patient is a classic example of difficult mask ventilation. So once you induce this patient, so this is a candidate where you need to secure the airway with an awake fiber optic intubation. So you can't intubate this patient with a general anesthesia or after anesthesia. So once you induce the patient, or even before, with or without paralysis, there is a very high chance that the tongue can fall back and patient can go into apnea. At this point of time, giving the situation of his limited mouth opening and severe trismus, it becomes impossible to near impossible to insert any oral airway or a supraglottic airway. So this is a case of anticipated difficult laryngoscopy. To my left, this is a patient with CA thyroid with post-op radiotherapy, and you can see the trachea is grossly deviated. Though his mouth opening is adequate, so intubation and securing an airway would be near impossible in such kind of scenario. So this patient is a classic example of difficult laryngoscopy. This is another patient with CA thyroid, papillary carcinoma of thyroid. So as you can see, this entire structure, this is engulfing the entire trachea, making it the complete distortion of anatomy of the entire trachea. So this patient, though her mouth opening looks adequate, once we induce the patient and once we paralyze the patient, it will be impossible for us to both ventilate and intubate the patient. So we land up in a CVCI scenario. So this patient also, we need to do an awake fiber optic intubation. So this patient is close to my heart. So this patient is a young male who sustained 3rd-degree burn. So on contact with a high tension electric wire, causing severe 3rd-degree burns to the nape of the neck. So fortunately, his mouth opening was adequate. So though his mouth opening was adequate, there was limited extension at the neck. So making it tough for us to align the oral, pharyngeal and laryngeal access. So hence we decided to go ahead with intubating the patient. So in this point of scenario, we were confident that we would be able to ventilate the patient adequately. So at this point of time, we had a plan of intubating or securing the airway in this scenario after induction of general anesthesia. So once we have induced the patient, once we are confident that we are able to ventilate the patient adequately, then we could we proceeded with this video laryngoscope. So once the video laryngoscope, this is the view of the vocal cards. So we could secure the airway and we could extubate the patient on table. So this is another classic example which we encounter in our day-to-day practice. So in this is a postbone contracture patient in which the mouth opening is very limited. So, and in this patient, as described previously, to make the patient comfortable, it will be impossible for us to give the airway blocks because the anatomy is altered. So, and this patient, we need to nebulize the patient and we need to do a transoral spray. So this patient is again an ideal candidate for securing the airway through awake fiber optic intubation. So this is a patient which we managed during the second wave. So this is a this is a middle-aged man with the post-COVID pneumonia with severe uncontrolled type 2 diabetes mellitus. So this patient, he had severe mucormycosis infection, and post-COVID and post-mucormycosis infection, his mouth opening was very restricted and patient was emotionally much deprived. So this patient had both limited mouth opening and is a difficult airway, and his neck extension was also very limited. So as this surgery was scheduled for an emergency fess and debridement, we could not do a awake fiber optic nasal intubation. And his mouth opening, though, as his mouth opening was minimal, we could not do a oral approach of securing the airway. But we were confident of that we could be able to ventilate the patient. So we managed this patient successfully with video laryngoscope. Coming again, this is a patient with middle-aged man with post-COVID pneumonia, uncontrolled diabetes, mucormycosis, difficult airway, coming for emergency fess surgery. So this patient, this case report we have recently published in one of the standard PubMed journal. This is another patient. This patient was coming for an elective lap chole. Though this patient, coming to the old history, this patient is a known case of CA buccal mucosa, post-op case. He received 30 cycles of radiotherapy. So post-radiotherapy, his airway was completely distorted. So then though his mouth opening looks adequate, but if you focus on here, his airway anatomy is altered. So we decided to intubate the patient through awake fiber optic intubation. Patient was very cooperative. On the left side, you can see one of our PGs giving airway blocks. So then we could intubate the patient. This is a small video. So this patient we could successfully intubate. So on fulfilling all the criteria of extubation, we could extubate the patient. Towards the left side, towards my right side is the smarty man, our ISS secretary, Dr. Sharad. He helped me a lot in securing the airway of this patient. And this patient we could extubate successfully, and the surgery was uneventful. Surgical airway. However, in spite of the best institutes and in spite of the best infrastructure available, we may have a situation where in this kind of situation, this was a 25-year-old man with history of animal attack and his entire face was charred. This is a situation where you cannot intubate, cannot ventilate, and you cannot pass it awake fiber optic. There's no nose, there's no oral, nothing. Everything is charred. So this is a patient where you secure the airway with a definitive surgical airway or an elective tracheostomy. So these are the advanced gadget. Towards my left, this is a CMAC laryngoscope. So apart from with an added advantage to the video laryngoscope, CMAC gives you an extra mileage of more comfort to the patient and less pressure on your incisor teeth. And when you are performing a laryngoscopy or once you are doing an intubation, there's less hemodynamic response. These are the advanced gadget which helps us in securing the airway in either any of the such difficult scenarios. Coming to take-home message or a question here. So always, whenever you are attempting for any difficult airway situation, be it anticipated or unanticipated difficult airway, so always, first of all, if you know the problem, there is no problem. So first of all, you need to have a series of questioning, thorough evaluation, and it needs a multimodal approach, and you need to have multiple hands helping you. So first of all, you need to ask these 9 questions. First of all, is there any previous airway issues? Is there any altered cardiorespiratory physiology in this patient? So is there any impact of surgery on the airway, or is your airway being shared? So if there is there any limited mouth opening which makes your bag and mask ventilation tough? So in case if you feel that bag and mask ventilation is yes, so if you are anticipating that you are going to have a difficult time in ventilating the patient, how difficult is it to place an airway device, for that matter, supraglottic airway device with this limited mouth opening. So how difficult is it to intubate the patient with or without anesthesia? So actually, as on today, it makes sense with new advanced selective alpha-2 agonists and with pediatric bronch and with good good training programs for awake fiber optic intubation. It makes sense to secure any airway, any difficult airway, anticipated difficult airway through awake fiber optic intubation with good, if you can give good blocks, and if there is a good patient cooperation, and if you can manage the patient with awake fiber optic intubation, there's majority of the catastrophes can be avoided. However, with the previous in the previous discussion, as madam said, you have to be very cautious about the LA toxicity, and you should always be keeping a watch on the amount and volume of the anesthetic drugs which we have given, which we are giving either for a block or a transtracheal route or through nebulization route. And always think for the risk of aspiration. Not necessarily we have a comfort zone like our OT where the patient is well prepared, patient is fasting, you have a multimodal, you have a multiple teams, or you have so many patients, so many people helping, you have a technician. You may be called to secure an airway in any remote location or in a ward, where by the time many people would have attempted for such kind of intubation, and many people have attempted, and there would have been an airway edema, or sometimes there can be airway trauma. So always weigh for the risk of aspiration, and always think of the ease of extubation. Majority of the scenarios, in any such scenarios where you secure the airway with so much of effort and those things, never ever try to extubate the patient on table. Always try to extubate the patient in a comfort zone. So again, coming again, the major change from 2013 guidelines in the management of difficult airway is awake intubation or awake fiber optic intubation. The reason for this is undoubtedly the wisdom of utilizing the awake intubation with significant risk of difficult airway. So it's also noticed that there is a minimal amount of mortality and morbidity when you attempt the patient with awake fiber optic intubation. So the net benefit of placing endotracheal tube in awake patient is always immense, as discussed previously. So the other major change which they noticed is optimize the oxygenation throughout. Just a minute. So the other major change they have noticed is optimize the oxygenation throughout. While attempting any intubation in an anticipated difficult area scenario, it's always recommended to give high flow nasal oxygen. As discussed previously by one of our eminent faculties, it's always safe to give a high flow nasal oxygen in such scenarios. So you can pre-oxygenate the patient with 3 to 5 minutes with 100% oxygen. So majority of the times you can avoid the catastrophes. The other major change they have noticed in 2021 guidelines is limit attempts. So this comes this after induction of general anesthesia. So this is a failed pathway. This again comes in a failed pathway. Limit your attempts. This is majorly to prevent repeated unsuccessful intubation and wasting and exhausting all your time and energy. This gains again adds value to prevent this again limit your attempts and call for help and try to ventilate the patient and try through a supraglottic airway device or through an oral device, so you can decrease the hypoxic brain damage significantly. So other change which is noticed here is limit the attempts and awake the patient. So this is mainly an emergency pathway, as you can notice. So if the ventilation is not adequate, and always don't push yourself into panic, and don't exhaust yourself by doing multiple attempts. So always the final change, which is limit your attempts and call for help, and always keep your difficult airway cart or difficult airway trolley handy. And whenever you are handling a difficult airway scenario in a controlled environment, always make sure that you have your surgical friends or your ENT team, so that once you are, though even of the best of the infrastructure, sometimes you may not be able to this thing. So in case you lose the airway, your friends or your colleagues or the ENT surgeons or surgeons for that matter, they will be able to secure the emergency surgical airway, so that you are majority of the time you're safe from the mortality and morbidity. So apart from this, nothing. I personally believe that nothing in this world is a one-man show. It's always a teamwork that brings success to you. And I thank my team for helping me to handle and comfortably manage all the difficult airways till date. So I thank one and all for giving me this opportunity. Personally, I thank Dr. Sharad, our secretary, for giving this opportunity to talk to me, giving this talk. I thank our chief guest, Dr. Venkat Giri sir, guest of honor, Dr. Rekha Das madam, and special invitee, Dr. Parveen Banu. And I'll be glad to take a couple of questions. Thank you.
Thank you, Dr. Vamsi. It's such a wonderful and complete presentation. Actually, I have also learned so many things from your presentation. It's really very interesting, and the way you are managing. In our institution, I am just being in charge in surgical OT. So usually what the cases which we are getting, that is maybe like postbone contracture, something like that. But yes, you are facing so many difficult situations and it's so nicely tackled. I don't know whether there is any question in the chat box. Is there any question? Yeah, someone raised hands, please. Any question? I think there is no question. So,
excuse me, ma'am. Dr. Umesh wants to ask some question. Dr. Umesh. Hello, Dr. Umesh.
Umesh sir, can you hear me?
I can hear you, Dr. Vamsi, but Dr. Umesh has raised his hand, so I'm waiting for his response. Okay, this may be the. So as such, there is no question.
We will take the question at the end of the session.
So, Dr. Sharad, may I conclude this particular session here?
As such, there is no question, ma'am. So your remarks and you can conclude it so we can move to the next pro and con session.
Pro and con, yeah. I think that will be another interesting topic, that whether pregnant patient, what should we do, that supraglottic airway or not. Better we move on to the next topic. Thank you, Dr. Vamsi. Really.
Welcome, madam. My pleasure, madam. My pleasure.
Dr. Vamsi, excellent presentation. Well done.
Thank you, sir. Thank you, sir.
So, thank you, madam. So, we are moving to our third presentation of the day, that is pro and con session. And for this, I would like to invite our senior, Dr. Gautam Saha, sir. Gautam Saha, sir, doesn't need any introduction. He's the stalwart in the field of anesthesia, not in our area, all over India, in fact. So, without wasting time, I would like to invite Dr. Gautam Saha. Dr. Gautam Saha, sir.
Good evening, Sharad. Am I audible?
Yes, sir, you are audible, sir.
Okay. Good evening, everybody. It was really an academic treat hearing our two earlier speakers. And what is most heartening, that it was very practical thing and it was practically demonstrated. That's what it made it all the more interesting. And I should congratulate Sharad and all those people here. We have been taking a lot of interest in this academic activity and is really given the academic fillip to the Bihar and Jharkhand. Now we are coming to today's topic, pro and con debate. Supraglottic devices in obstetric patients should not be used. Ever since we have been in the medical college doing our post-graduation anesthesiology, we have been taught that is the gold standard in a cardiac, in a cesarean patient who's undergoing general anesthesia to secure the airway using an endotracheal tube. But with the present generation, a lot of supraglottic devices have come into clinical practice. Now, the key concern where obstetric patients undergoing general anesthesia is the risk of aspiration. Now, over the next couple of minutes, our two speakers, Dr. Saurav Suman and Dr. Madhukant, they will debate that should supraglottic devices in obstetric patient be used. And for the speaker, is Dr. Saurav Suman, who is an assistant professor, RIMS Ranchi. So I invite Dr. Suman to speak for the topic, but please stick to your time limit, that's 10 minutes.
Yes. Good evening, Venkat Giri sir, Rekha ma'am, Praveen Banu ma'am, Gautam Saha sir, and other distinguished member of executive committee and other respected faculties and residents. I am Dr. Saurabh Suman, Assistant Professor RIMS Ranchi. Today is my proud privilege to speak in front of eminent anesthesiologists. Today I'll discuss why supraglottic devices in obstetric patients should not be used. This is my institute, Rajendra Institute of Medical Science, and this is my city. Why we are so much concerned about the pregnant airway? First, 2 lives are associated with parturient. Second, edema of tongue and larynx makes their airway very difficult. There is a capillary engorgement of airway mucosa, so there is increased chances of fragility and bleeding. There is increased chance of epistaxis. That's why nasal intubation is not indicated in this case. Shortening of distance from chest to chin, that makes insertion of supraglottic airway devices difficult, as well as laryngoscopy. Other changes during pregnancy are the combination of decreased functional residual capacity and increased oxygen consumption. And because of that, there is a rapid oxygen desaturation during apnea period. So, second one is reduced gastric motility and incompetence of gastroesophageal sphincter. It happens because of estrogen and progesterone that causes incompetence. There is an increased release of gastrin because of placenta that decreases the pH. And that's why all parturients are considered to have a full stomach, because there is increased chances of regurgitation and aspiration. And hence, supraglottic devices should not be used. This is a very interesting study. Airway in the pregnancy is difficult, but what makes it more difficult? There is one study of a 17-year experience in a teaching maternity unit published in British Journal Anesthesia. And they observed that the failed intubation occurred more during emergency cesarean section and off-peak hours, and with less experienced anesthesia personnel. So experienced anesthetists should be available even at call at night. Malposition of supraglottic airway devices. Insertion of supraglottic airway devices is virtually a blind technique. And imaging studies have shown that malpositioning of supraglottic devices occurs in 50 to 80% of patients. These are the different malpositioned picture taken through video laryngoscope. There are mainly 5 causes of malpositioning of supraglottic devices. First, if a tip of distal cuff of supraglottic devices folding backward, or it goes between the vocal cord, or epiglottis going in ball of supraglottic devices with downfolding or without downfolding, or there is a double folding of epiglottis. What are the predictors of difficulty with supraglottic devices? First one is reduced mouth opening insertion during application of cricoid pressure. Then increased BMI, if there is increased intra-abdominal pressure, if there is a laryngospasm or bronchospasm. And what we see in obstetric cases, there is increased BMI, there is increased intra-abdominal pressure. And while inserting, you have to apply cricoid pressure. And that makes very difficult insertion of supraglottic devices in parturients. And that's why it should be avoided. What are the complications that are associated with supraglottic devices? First one is the aspiration of gastric content, which is of our concern mainly. Though incidence is very less. Second one is trauma. It may cause trauma to all the structures through which it passes, like laryngeal apparatus, uvula, epiglottis, tongue, teeth, and lips. It may cause laryngospasm, nerve injury, like injury to lingual nerves, hypoglossal nerve, recurrent laryngeal post-operative sore throat. Even it causes reduction in diameter of carotid vessel, though it's not so important, but in case of cardiopulmonary arrest, it may be detrimental because it will decrease the blood supply of cerebral vessels as well. And it may cause negative effect on oropharyngeal mucosa if there is hyperinflation of the cuff. This is a master algorithm for obstetric airway. In first algorithm, there is a pre-induction planning and preparation as well as team discussion. We do modified rapid sequence induction with maximum pressure, peak pressure of 20 centimeter of H2O. Maximum 2 intubation attempt is taken. Third is by experienced colleague. Main aim to explain the DAS guideline 2015 is that the role of supraglottic devices only come when the intubation fails, not as the primary adjunct. This is All India Difficult Airway Association 2016 guideline. Here also intubation is preferred over supraglottic devices. This is the ASA Difficult Airway algorithm 2022, very well explained by Dr. Vamsi and Dr. Priyanka. Here also supraglottis is not preferred over intubation. This is an article published in British Journal of Anesthesia 2020. They say the gold standard for airway management in obstetric general anesthesia remains rapid sequence induction and tracheal intubation because of the perceived risk of regurgitation and aspiration in the pregnant women. So what's the future? Currently, there is insufficient evidence to recommend universal or selective replacement of tracheal tube with supraglottic devices. During general anesthesia for cesarean delivery, aspiration remains the main concern. This is a meta-analysis published in 2020 in Analgesia and Anesthesia. Result is here 14 studies were taken and more than 2,000 patients were enrolled, and they compared supraglottic devices with endotracheal intubation. Overall, there was no statistically significant difference in the first attempt success rate. There was no significant difference in the time to insertion. So the conclusion is, despite the reasonable insertion success rate and safety profile of supraglottic devices demonstrated in this meta-analysis, the analysis remains underpowered and therefore inconclusive. Given the high first attempt success rate demonstrated, the use of supraglottic devices following failed intubation is likely to be more effective and potentially than repetitive intubation attempt. So the take-home message is gold standard for airway management in obstetric patient is rapid sequence induction and tracheal intubation. Recent guidelines as well as recent studies don't support supraglottic devices as first-line airway in obstetric patient. They can be used in case of failed intubation as rescue only. This quote is very suitable while doing airway management. If you fail to plan, then you are planning to fail. Thank you. Thank you.
Thank you, Dr. Suman. It was an excellent presentation which you made. In fact, I have also gone over those articles which you have just shown just now, you know, and you have got a point of view, but your other friend, Dr. Madhukant, he has a different opinion from what you say. Let us hear what he says, and then we are going to invite questions from the house, and you're going to rebut each other for you'll be given 2 minutes to rebut each other's point. So I welcome Dr. Madhukant to give his viewpoint. Dr. Madhukant, are you there?
Sir, Dr. Madhukant is having network issue. I just called him. He is having network issue. So he's joining in a minute. He was joined, but somehow.
In the meantime, if the house has any questions for Dr. Saurav Suman, they can put the questions to Dr. Saurav. I have got one question for you, Dr. Saurav.
Yes, sir.
You must have read in the article, the same article which I have also gone through, to stratify the risk of the patients who are going to undergo a general anesthesia for cesarean LSC, it is a lower section cesarean section, they have been using ultrasound.
Yes, sir.
Ultrasound.
Yes.
So if we are using ultrasound, and we can assess the degree to which the stomach is empty, should we not take the help of supraglottic airway devices, because it avoids many more complications such as laryngospasm and many other. It helps in maintaining a better hemodynamic profile. What is your opinion regarding this?
Yes, mainly supraglottic is avoided because of the risk of regurgitation. So if we do gastric ultrasound and see the content, if there is a less content or there is no content, proper NPO we have maintained of more than 6 hours or 8 hours, we can go for supraglottic devices as well, because there will be less risk of regurgitation. In that case, you don't need to intubate the patient. That's the
in fact, in one study I have read that 8 out of 8,000 cases where supraglottic airway devices were used, not a single case of regurgitation, no, aspiration has taken place. Yes, but while applying fundal pressure, only one case of aspiration has taken place.
Yes, sir. Yes.
So out of 8,000 cases, in one case of only aspiration, regurgitation takes place. I think it is considering that hemodynamic status, hemodynamic status remains on the safer side, and patient is not having allied complications, we can use supraglottic airway devices.
Yes, sir.
We should go in for it because it has definitely got certain advantages. I don't mean to say that any particular method or particular approach is absolutely correct. But we should, when new things are in progress, there are supraglottic airway devices which can help in intubation. The supraglottic airway devices through which you can aspirate the go for aspiration of the stomach also.
Yes,
so
sir,
we have to keep this in mind before we completely go discard the this particular approach.
Yes.
I still believe that securing the endotracheal airway where it is required, and if you think that the gastric emptying is not adequate, or the patient has had a food a short time back or fluid short time back, we can go for rapid sequence intubation and go for securing the airway.
Yes.
But we cannot definitely completely discount, because a study has shown, even though it is many studies have shown, the supraglottic airway devices, especially where difficult airway is encountered, we can go for it, especially even in cases of low LSCS cases patients.
Yes, sir. There is a very less incidence of regurgitation as well as aspiration. So we can go for supraglottic devices as well, if there is a proper NP or we are doing gastric ultrasound. Or
any other questions from the house? Dr. Nishant? Dr. Nishant?
No, sir. Nothing in particular. I think if Madhukant is not able to join in, we'll just know in a minute or two. I have some rebuttal slides for Saurav, and just we can have a little discussion then.
Okay, please do. That would be interesting. Please, Nishant, go ahead. If Madhukant joins, you can go ahead.
Okay, sir. So with your permission, may I?
Please do.
Hi, Saurav.
hello, sir.
Can I say something?
Yes, ma'am.
Absolutely.
Yes. Even the second generation of supraglottic airway device, as you must be knowing, has a port for aspiration. So even if the fear of microaspiration is there, that can be avoided because of this, in addition to doing an ultrasound and seeing what is the residual gastric volume. So these can be add-on things which you can prevent major aspiration, microaspirations. So supraglottic airway device is an innovation, is a path breaking in obstetric patients. But then as you all say, that fundal pressure and how much you are applying, that is also very important. If you have a good cooperative and if your situations are favorable, so here you can go for a supraglottic airway device and you can also prevent aspirations. So all these things have to be favorable. Like the obstetric part also has to be favorable. That is a very important.
हाँ sir, क्या हुआ उसका?
Dr. Madhukant?
तो mute है. Okay, sorry.
Dr. Nishant?
Yes, Dr. Nishant can say something. Add on.
Hello. Dr. Nishant?
Sorry. Am I audible now?
You're audible now. Absolutely audible. Please
Okay, I'm sorry. I was searching for this mute button. Are the slide visible?
Very good. Very clear. Very clear. Please
So,
go ahead.
sir, yes. So actually what had happened was Madhukant had shared some of his slides with me. And just because he's not been able to join, I'll just try and run through his slides.
Okay. Please do.
And yes, sir. So there are special considerations with the pregnancy and supraglottic devices. And we at our institute also, sir, we regularly use supraglottic devices, but not so much in pregnant patients. As there are very definite usages and advantages of supraglottic devices. And there is no doubt, I'm sure even Saurabh will agree, that for failed tracheal intubation, the supraglottic device has a definite place. And nowadays, sir, what we do is mostly it is the second generation supraglottic devices which are used simply because of the use of the gastric port. So anytime we use a supraglottic device, mostly it is a second generation where after placement, and especially important in obstetric patients, that we suck out the, then the assessment after putting, especially in a failed tracheal intubation, would be whether the oxygenation is possible. And if it is yes, then whether it is safe to proceed with the surgery. And if it is not safe to proceed with the surgery, then we wake up the patient, or we either go ahead with the surgery with the supraglottic devices. And even though it has not come in textbooks, but there are very many studies which have proved that supraglottic devices are safe. And this is one absolutely important place where supraglottic devices must be there, because there can be obstetric failed tracheal intubations for a variety of reasons. We know that. So whether to proceed, we must consider the maternal condition, the fetal condition, the comfort of the anesthetist using the supraglottic device, and these are the other factors that we can consider. Okay, so these are the considerations by which we decide whether we can proceed with the surgery using a supraglottic devices or not. What I feel is, once, if it is a good seal, now with every supraglottic device, what we have to understand is that the sealing should be checked and the gastric decompression should be done. Once these two are done and the sealing is good, I think we can be good to go, especially if the maternal condition or the fetal condition in a failed tracheal intubation permit us to go ahead. We must go ahead with the supraglottic device itself. So airway management with the supraglottic device has been compared, because the pregnant patients, there is an increase in the intra-abdominal pressure. And we have seen that supraglottic devices are used very, very frequently in laparoscopic surgeries. Now, in laparoscopic surgeries, the condition is that the intra-abdominal pressure is high. And if in laparoscopic surgeries, we can very conveniently do, in fact, at our institute, all laparoscopic surgeries, be it lap chole or laparoscopic TLH repair, where it is a steep head down, we do with using supraglottic devices mainly. So with laparoscopic surgery, if you compare the intra-abdominal pressures, it will correlate very well with the gestational age. The problem is that after 32 weeks, the intra-abdominal pressure is around 13 to 14, and postpartum it is 8 around 13 to 14. So even in laparoscopic surgeries, we see that the surgeons here keep the intra-abdominal pressures around 13 to 15. And in no patients, and there are a lot of studies and meta-analysis in which supraglottic devices have been proved to be safe in laparoscopic surgeries. So the concern that there be an increase in the intra-abdominal pressure, in any case, once the baby is delivered, the intra-abdominal pressure will come down. So as I mentioned, there are so many studies. There is a study use of LMS Supreme in 700 parturients, and they found it effective, and there was a good seal, and there was no evidence of aspiration. That is the main concern, as even Saurav was saying, that the concern with supraglottic devices is aspiration. They evaluated ProSeal, they evaluated LMS Supreme. There are so many other supraglottic devices that have been evaluated, even BASCA nowadays, they have compared that the sealing pressure of BASCA is better than ProSeal, which has a double seal mechanism. So likelihood of that use in obstetric patient will also be high. Sir, actually, I'm not prepared, so please pardon me on the time. I'm not sure how long I'll be taking. So again, you can see that.
Go ahead. It's interesting. Go ahead.
LMA, yeah, the ProSeal LMA used in cesarean section. This is an experience of 3,000 cases, sir. So and this was done in way back in 2010. So the supraglottic devices have been used quite extensively, even in obstetric patients and elective cesarean sections also. There was a comparison, interesting comparison between igel and endotracheal intubation in patients undergoing cesarean section. Now, this is what we want. This is the crux of the talk today. And this article, which was a randomized control trial, showed that igel could be a better alternative to endotracheal intubation in patients undergoing elective cesarean. What I believe is, the reason one is intubation in a pregnant patient might be difficult, but when we put in an igel, we are immediately deflating the gastric content. So the chances of aspiration are not only less during intubation, but it is also less at the time of extubation. This risk of extubation, this risk of aspiration during extubation is also very high. So this could be a very major advantage. Apart from that, we know that there are hemodynamic disturbances with intubation. When we put in a supraglottic and igel, we are not going to respond by giving fentanyl or other opioids. The baby might come out better if we are putting in an igel. We don't need to put the patient very deep also. If we are putting in a supraglottic, with intubation, we might need to go in deeper. So routine use of, this is an article by Anjan Trikha, sir. He's a name to be reckoned with from AIIMS Delhi. And routine use of laryngeal mask airway for the cesarean section, is it time to reconsider now? If somebody of the stature of Dr. Anjan Trikha is reconsidering, then we all need to sit up straight. So he believes that there is still not evidence that ET can be replaced by LMA or PLMA for use in GA. But if they are used, careful patient selection and expert anesthesiologist is essential. Now, this is the most important part. The anesthesiologist needs to get experience in the supraglottic device before he can be confident of use in an obstetric patient. Because even in a normal patient, when we are using a supraglottic device, if there is a leakage, if there is spillage, we will take it out. So the risk is the same with the obstetric versus the non-obstetric patients. So I feel he believes that there are various uses of supraglottic devices, and obviously to ventilate before intubation, we can use it as a conduit for intubation. That is another very important use. Suppose you have to believe that intubation is very important in this obstetric patient. igel and all these intubating LMAs can be used, whatever we are familiar with. We can actually also conduct anesthesia if we feel that everything is under control, and disturbing the airway and disturbing the patient at a critical time, as in an emergency, might be difficult. As I mentioned, it can be used as an aid during extubation. Once especially in asthma patients, if there are severely asthmatic patients, you can replace the endotracheal tube with the supraglottic and then gently wean off the patient. And emergency airway management, this is a very definite use of supraglottic devices in obstetrics. And this is one reason why we believe that supraglottic devices should be there in every labor room, every gynec OT. I think this is the last slide, sir.
Thank you, Dr. Nishant. It was a good presentation, and thanks that Dr. Madhukant had shared his slides with you. We could go ahead with today's year. And the arguments which you have put forward, they seem to be quite logical. Even Dr. Trikha is in favor of it. But one thing, as you added a word of caution to it, they should be in experienced hands. So with I would like to conclude today's session with the following words, that even though endotracheal intubation remains the gold standard, and for a beginner and for inexperienced people, one should always have an access over the endotracheal intubation and to control the airway. But supraglottic airway, it opens up new opportunities with the help of ultrasound, with the help of newer techniques and newer devices. It can help in securing the airway, especially the difficult airway in a pregnant patient. And it holds out a lot of hope, which we must not discard. I congratulate both the speakers for making such an essential contribution and making it a very interesting session. If there is any question from the house, it's most welcome. Otherwise, over to Dr. Sharad.
Sir, I have one question. Good evening, sir.
Yes. Go ahead.
I have a question with Dr. Nishant. Nishant, very nice presentation. Maybe you have gone through the article. I have a question like which supraglottic device is best for using cesarean section? Whether it is LMA or ProSeal or like iGel. Is there any article regarding this?
So, sir,
good question.
Sir, actually, I have not gone through articles of late regarding that. But what I believe is for an obstetric patient, the concern will be aspiration. Yeah. Now, for an aspiration, all the supraglottic device, it has to be a second generation supraglottic device, sir, which has a gastric channel. So the question of LMA goes out of the picture. First generation, which does not have any gastric channel. That is what I believe. Regarding the sealing pressure, now to begin with, first the supraglottic device which we are comfortable with, the user is comfortable with, we should go in for that, because there is some academic difference in the sealing pressures. There are studies which have been done which have compared iGel versus ProSeal versus BASCA. Now, what they have found is that the iGel is the easiest to insert. The user friendliness of iGel is the best, but the sealing pressure of BASCA is the best. Per se, I have not gone through because I have not gone through any study in which has compared BASCA in obstetric patients. But the sealing pressure of BASCA when you compare to iGel, so the sealing pressure difference is like BASCA is the best sealing, then comes the ProSeal or Supreme, and then comes iGel. But ease of use of iGel is better because there is no inflation, and so study-wise, it is not there. Given a choice, I would go in for iGel first. Probably then I'll go for ProSeal and then BASCA, because we have not used BASCA too much, even though it has good sealing pressure. I'm not sure about the literature, sir.
Moreover, Dr. Nishant, thank you very much. Even I went over an article. The one advantage of iGel is that because of the material which is made at the body temperature, it easily molds. It easily molds to the anatomy of the body, and that provides a better seal.
Or we can do like that, sir. We can put the supraglottic device and we can keep the rise tube always, because the obstetric patient anyway we are considering the full stomach. So with suction, or if we are using, I don't know how the people are practicing, but I never use supraglottic device in pregnant patient.
So in pregnant patients, what they do, sir, whatever I've seen is that they go in for RSI only. They go in for propofol with rocuronium, and they insert the supraglottic. Some people have used Selix maneuver, but Selix maneuver as it is not very useful even in the best of for endotracheal intubations. So once the supraglottic is placed, the gastric decompression is done, and then they go ahead. This is the practice at some places.
Yeah. Okay. Thank
And
you.
we always keep the gastric channel.
Yeah.
Always gastric channel there. Any other question from the house? Thank you very much, everybody. Over to Dr. Sharad.
Thank you very much to all of you. Especially, I want to thank Nishant, Dr. Nishant, for being the savior of the day. Thank you very much. I had a talk with Dr. Madhukan. He is having network issue because of this bad weather. He's sending his apology to the house. So, Madhukan, if you are hearing, nothing to worry. You will get another chance to present in some other CME. So, so we are moving on. As this is the 13th CME of the Bihar and Jharkhand Society of Anesthesiologists in continuous monthly. We started December 2020 during the just after the first wave. So with the help of all the executive members and the members of the BJSA, we are continuing, and hopefully in the next year also, or the next, we are planning to do something different. The scientific committee is working on it, how to make it more interesting. So we will come with that. We will let you know. The house will be aware about how we are going to present in the next lot of CME. That will be the 10 CME or the workshop we will have. So want to thank the chief guest of the day, Dr. Venkatgiri sir. So Dr. Venkatgiri sir, are you there, sir? Oh, I can see you, sir. Please unmute yourself. Your voice is not clear, sir.
Okay. I'm there.
Yeah.
I just switched off my. Okay. Okay. I can hear you. Right.
Yes, sir. So wanted to hear you about how was the presentation today, and your feedback, your observation, and how to move forward. It is important to get feedback from the seniors like you, sir.
No, good presentation and all that. Really good. And Rekha did very well. Rekha, she was doing excellent moderation. We should go like that only. See, more that what I think is we should have juniors. And now see what I found, because what was a little interesting in Kerala, PGs, they made 2 PGs to present. One person presenting drug, another person equipment. That is a good this thing. It's more exam oriented. Some PGs we can make that. So one PG will present every CME day. So that was very interesting, because last week it was propofol and laryngoscope. Another day it was thiopenton and LMA. That way PGs get benefit and more PGs will come. That you can think that, because I really felt that was a good. That's my suggestion. You can also think that every this thing give chance for 2 PGs. Some topics like that, because they will present and more PGs will come.
Thank you, sir. Thank you for the nice suggestion. We are working on it, but I don't know what is the problem. I am continuously chasing our postgraduate. Please come forward, present. Today also I messaged all of them that please join us, please listen to the stalwart and listen how to present. That is also very important. See how they are presenting, how they are speaking. This is also a learning process. But let's see. Hope they will come someday. They will present. They will join. So, thank you, sir. Thank you very much. Now I invite Dr. Rekha Das, madam, for her comment. Rekha Das, madam. I think madam left. Dr. Praveen, madam, are you there?
Yeah, I'm here.
Yes, madam, your feedback.
This is the first time I'm joining this kind of virtual CME organized from your end, and it's really very nice presentation. It's a real academic feast, and I think it will be of very good use for the postgraduate students. So I'll be happy if you give me more opportunities to be with you for the next CMEs and all.
Yes, madam. Thank you very much. You are always welcome. As as I said that we are doing it on a monthly basis. Every month we are doing it without any break.
Thank you, and with permission, I'm taking leave. Okay.
Dr. Sharad, any more queries from anybody? Dr. Sharad? Dr. Sharad, can you hear me?
Hello, am I audible?
Yes, you're audible. Now you're audible, Dr. Sharad.
Actually, sir, what network issue is going on? The hailstorm in Jamshedpur, sir.
Yeah, hailstorm is going on here also in Bokaro.
Thank you very much, sir. So I like to hear your voice, your comment on Dr. Gautam Das, sir.
It was a very, very interesting session, a very practical session, and I thank Dr. Venkat Giri, sir, Shant, and all the speakers, Rekha Das madam, Dr. Praveen Manu madam, for their wonderful contribution today. And I always thank you. You take a lot of pains and effort throughout the year to keep this CME going, and you have given chance to many young speakers and they have just done simply wonderful job. And I think, as Dr. Venkat Giri said some time back, we should concentrate on the postgraduate students, and that's where our focus should be from the future CMEs. Thank you very much.
Thank you, sir. Thank you very much, sir. Hello. We are having seniors like Dr. Gurmukh, sir, Dr. Murlesh Pala. Dr. Gurmukh, sir, would you like to say something? Please unmute yourself. Sir, Dr. Jami Sridhar, we are having Dr. Jami Sridhar from Canada. He is an experienced anesthetist. We would like to hear Dr. Jami. Dr. Jami.
Thank you, Sharad. It's almost 2 years I visited India now, but I think the Zoom programs have made our lifeline to interact with everybody. And yours being always at around morning 10 o'clock, where I usually get the free time. Now it's 10 o'clock. I just had brunch, whatever, rice, little bit of curry, whatever. Anyway, so it's nice to see you all, everybody. And now things are getting eased themselves. We will be off masks by 18th of March in Canada. There is no vaccination passports now needed after 18th of March. Now, all over Canada, wherever you go, you have to wear mask, show your vaccination record with the booster. If no booster also, you are not allowed inside the restaurant sometimes. And airports are fully barred if you are not vaccinated. So a lot of restrictions are still going on. Even in our operating rooms, we are still not taking COVID positive patients who are like 4 weeks ago or 5 weeks ago. We are still putting restrictions around 6 weeks now. But anyway, going forward, you are doing a good job. Keep posting. And I congratulate all the speakers. And thank you very much. And I will try to be a participant with you. So looking forward to share the dice with all the big guns. Thank you very much, Sharad. Thank you.
Thank you.
So please unmute yourself now.
Nishant, please share the slides.
Sir, 1 minute, sir. Visible, sir?
Yeah, visible. Yes, perfect.
So to begin with, sir, this is a certificate of appreciation for support who is a very source of big support for ISA Bihar and Jharkhand. And thank you, sir, for moderating the session today on the theme of airway. And with your very insightful words and your experience, this whole session was very richly enriched. Thank you, sir.
I request Dr. Venkat Giri sir, our President, ISA President National, to hand over the certificate to our esteemed moderator of the day, Dr. Gautam Saha. Dr. Venkat Giri sir, please give the certificate to Gautam Saha.
Okay, it is my pleasure to hand over this certificate to Dr. Gautam Saha on this day. Thank you. Thank you. Dr. Saha, it is my pleasure to give this certificate to you.
Thank you, sir.
Thank you, sir. Next, the first lecture of the day, Dr. Priyanka Shrivastava. She's faculty at RIMS Ranchi, and she presented her views on how she prepares a patient for awake fiber optic intubation, which was very enlightening. Thank you, Dr. Priyanka.
I think she just left off because of the network issue. She's not connected right now. So she will be given the certificate by Venkat Giri sir. Dr. Venkat Giri sir, please give her the certificate. Dr.
Right,
Venkat
sir.
Giri sir.
Thank you again. Dr. Priyanka this certificate for presenting her paper. Dr. Priyanka, it is my proud pleasure to hand over this certificate to you. Please accept.
Thank you, sir. So next is the certificate of appreciation to Dr. Saurabh Suman. He's also faculty at Rajendra Institute of Medical Sciences, RIMS Ranchi, and he discussed why supraglottic devices should not be used in obstetric patients in the pro-con session. Venkat Giri sir, please, could you do the honors?
Okay, thank you. It is Dr. Saurabh, please accept this certificate from ISA Bihar Jharkhand for your paper, and it is my pleasure to hand over the certificate to you this evening.
So next, the certificate of appreciation is for Dr. Madhukan. Unfortunately, he could not join, but he has put in a lot of effort, and he really sounded very disappointed that he could not make it, which is unfortunate actually. But he has put in a lot of effort, and for that effort, there is a certificate of appreciation for participating in the pro-con session. And supraglottic devices in obstetric patients should not be used. He was against the motion. He was on con. So Venkat Giri sir, could you please also do the honors for Dr. Madhukan?
Okay, sure. Nishant, as you have told during the talk that he has prepared, but he could not, unfortunately, he could not participate due to some issues. Anyway, he has prepared, and it was his slides and talk, which, as you have told, it is
Yes,
he should get this certificate for all his efforts. This appreciation certificate.
Absolutely.
You can hand over to Dr. Madhukant. Send it to him. In his absence, handing over to him. Thank you.
Right, sir. Thank you so much. And
thank you very much, sir. Thank you, Nishan. And
last certificate of the day is Dr. Vamsi.
Yes, Nishan. Would you like to say something?
This last certificate of the day for Dr. Vamsi Upalapati. Dr. Vamsi.
Okay, Nishan, thank you very much
for I'm here.
Presenting in a very short 1 minute notice. And special thanks from all of us, always the savior from our side.
That is not needed, sir. Thank you, sir. Thank you so much.
Thank you, sir. Thank you. Good night. Good night.
I think Dr. Sharad sir is muted again.
audible?
Yes, yes. You are audible, sir. Please go ahead. Hello, sir.
Sharad sir, you are not audible. Sharad sir.
No,
you are
you're not audible, sir. Sir, he has a second account also.
Okay. Okay. That sound is very low.
Yes. Now he's back again. Sharad, sir. Should we conclude the session for today, Sharad, sir? Say something, sir. Dr. Naseem, sir, is here, but your voice is very low, sir. You're not very audible. Dr. Naseem, sir, is not here. So I think, sir, with your permission, Venkatgiri, sir, Dr. Ajay, sir, is here. Dr. Ajay? Ajay, sir, could you please unmute yourself?
Hello. Good evening to all of you.
Good evening, sir. Sir, just parting comments, sir. We are just finishing for the day.
Yeah. Today, the Airway session is very nicely presented by all speakers. And I have seen the video of Madam has a very nice video. And after that, ये सौरभ का भी काफी अच्छा रहा. I think very useful to us. गौतम साहा सर काफी अच्छा presentation था और काफी informative रहा. मतलब overall सारा चीज अच्छा रहा और yes, it should be continue. शरद बॉस अपने आप को अनम्यूट किए कि नहीं किए?
Hello, am I audible?
हाँ शरद बॉस आवाज आ रही है.
हाँ, lots of network issue going on. No Wi-Fi working.
Sharad boss, good evening to all of
Dr.
you.
Manoj आ गए. Just a minute.
शुरू से हैं.
Just a minute. I am requesting Dr. Naseem Akhtar or Dr. Vikas from Ranchi City Branch to give officially the vote of thanks. Then we can have some discussion of Dr. Naseem Akhtar. Are you there? Hello, Dr. Naseem Akhtar. Hello. Okay. Dr. Naseem or Dr. Vikas from Ranchi City Branch are not present at this moment. So I would like to invite our senior member, Dr. Manoj Kumar, the ex-GC member of Bihar and Jharkhand, to say a few words. आप लोग सब कोई वीडियो ऑन कर सकते हैं now, please.
Very nice presentation by all speakers. Many congratulations to all speakers who presented airway session very nicely. I am very thankful to Rekha Das, our GC member, and President West Bengal Society of Anesthesiology, Dr. Praveen Bano, as a moderator. And I congratulate our ISA Bihar Jharkhand executive body, especially President Dr. D.K. Singh and Dr. Sharad Bose, who gave 100% effort for raising our flag of ISA Bihar Jharkhand in a very high level. Thank you very much. Thank you, Sharad Bose.
So thank you, Dr. Manoj, for your nice word. Actually, this is the team effort. I always say this is the team effort because of members like you, Dr. Nishant, all the committee members. They are working always, giving me input. ये करना चाहिए, ये करना चाहिए. This is because of them. The Bihar and Jharkhand is doing hopefully we are doing the right things. Dr. Venkatgiri is the right person to tell how we are doing it and how to add something to make it more interesting, more usable for all the faculty as well as the PG students. So Dr. Venkatgiri sir is the right person to give the feedback about everything what the Bihar and Jharkhand is doing. So officially we have closed the program, but we can take the feedback of Venkatgiri sir because this is the moment we can get some input from him, Dr. Venkatgiri sir.
Yeah, I don't know. The clinically interesting. Another thing is what we should have that more than a theory. What we taught in national also, clinical situation discussion of the clinical situation, giving a case scenario and discussion. That may be sometimes more interesting. Actually, see, we can have different varieties and different. One, as I said, the PG session at the course so that PGs will attend for exam oriented. A case scenario that like that 30-year-old woman, full-term pregnancy had, she said, very post-cesarean, she had BP fall or this thing, the use of this thing, what will you do that? How will you manage the case? Some cases, actually, what we are seeing that sometimes occasional cases, the experts, so it will be more, that's what even national level also we are thinking, we should have something like that. A case scenario and actual case which happened, we can make that. See, it's not one day. You can ask somebody who is good in that, tell that, okay, can you discuss this? Because instead of more theory, because everywhere people get theory, so many, even national also we are getting into. Change that so that it will be more interesting and people will come there. Let us see that. You can also try both. PGs also can participate so that more PGs will come. You can ask one college, one presentation, maybe one PG will present and tell all the, their HOD can moderate that session so that there are more PGs and they are interested and ask what they want. Exam oriented will be one drug, everything about that drug or an equipment we can think. That's also maybe 20 minutes, you give that in 2 hours, one PG. He will present, he or she will be presenting.
Thank you, sir. Thank you for your input. Actually, we are trying our level best to get the PG involved in our CME. But I don't know what is, why they are not joining, why they are not presenting. I am personally interacting with them every day, but there is something I don't know. So first time we are having Dr. Vamsi with us. Dr. Vamsi, hello. Dr. Vamsi, first time is presenting at this state level online. So wanted to get your feedback also. I was.
Yes, sir. It's first of all, I should appreciate your efforts for bringing it live. So, and I personally have so much of gratitude and your motivation, being your colleague. I always see you as a fighter. Always, every crisis, no, you convert into an opportunity. That's your favorite quote. Every crisis gives you an opportunity. So had it not been a COVID, no, interacting in so much with so much colleagues, someone from Canada, someone from Kerala, someone from Uttar Pradesh, someone from every part of the world, it's impossible. So this is a way we need to grow. This is first feedback, and I appreciate you. I sincerely thank you for getting me and giving me this opportunity. And to make this session interesting, no, as our Venkatgiri sir said, we need to bring more case scenarios. So difficult airway, when you see the chat, no, everyone may not get connected or may not feel it interesting. Emergency pathway, non-emergency pathway. That's the reason why I showed various case scenarios. Cannot intubate, cannot ventilate scenario, restricted mouth opening scenario, a patient with limited neck extension where laryngoscopy will be tough. So I focused on various scenarios so that to make it interesting. So as sir rightly said, no, we should involve postgraduates so these are the young doctors and these are our future. They have to take take it forward. So if we involve them and we give more encouragement and more incentives and more participation, I think we have to do. And coming to the next ISACON, which is going to be held in Shillong, I think this can be the theme. And we have to put more interesting and more reality, more simulation, more this kind of programs. Over to you, sir.
Thank you, Dr. Vamsi. Thank you very much. So I see few names: Dr. Ajay, Dr. Lata, Dr. Bimlesh, Dr. Khushbu, Dr. Jagdish Misra, sir. If you want to say something, please unmute yourself and. Okay, so as I just see no hand raised, so can we conclude the session? Dr. Ajay Mishra, Dr. Ajay Kumar, कृपया वोट ऑफ थैंक्स आप दें, कृपया वोट ऑफ थैंक्स दें.
अरे बॉस आप हैं, आपके रहते.
अरे नहीं नहीं, हमेशा हमेशा हम तो हैं, लेकिन चलिए प्लीज कृपया वोट ऑफ थैंक्स दें. हमारे साथ हमारे सम्मानित नेशनल प्रेसिडेंट डॉक्टर वेंकट गिरी हैं.
सबसे पहले तो हम अपने नेशनल प्रेसिडेंट को प्रणाम करते हैं और बहुत अच्छा लगा कि हमारे बीच वो उपस्थित हुए और हमारे इस सीएमई प्रोग्राम को, इससे हम लोगों को और इंकरेजमेंट मिलता है. हमारे प्रेसिडेंट सर आए, पिछले बार हमारे नेशनल सेक्रेटरी सर आए, तो ये काफी अच्छा लगता है. और हमारा जो मैं देख रहा हूँ कि जो टॉपिक जो सिलेक्ट किया जा रहा है वो काफी मतलब यूजफुल टॉपिक और सबके लिए. और ये शरद बॉस को थैंक्स कि आप इस तरह से आप अच्छे टॉपिक सिलेक्ट करके और अच्छे स्पीकर को इसको जोड़ रहे हैं.
यहाँ पे एक चीज बोलना चाहेंगे, हम हमेशा जो करता है उसका नाम हम पब्लिकली लेना पसंद करते हैं, तो इसके लिए हम सबसे पहले अपने प्रिय निशांत सहाय को धन्यवाद देना चाहेंगे. ही इज ऑलवेज देयर. निशांत जो भी
कभी निशांत
वो एग्जैक्टली
निशांत का तो खैर कोई जवाब नहीं है. मैं शुरू से ही उसका भाई साइंटिफिक में उसका मैं एकदम कायल हूँ, मैं बता नहीं सकता हूँ. और जितना अच्छा उसका he is a perfectionist in scientific
sessions. Thank you so much. Thank you, sir. Thank you so much.
और काफी अच्छे ढंग से मॉडरेट करना हो या किसी चीज को किसी तरह से मतलब एक्सप्लेन करना हो, एकदम निशांत इज वेरी नाइस. और हम चाहेंगे कि आगे भी निशांत इसी तरह से जुड़ा रहे और आगे सबको सारे लोगों को, सारे स्पीकर्स को, सबको जोड़ करके. और काफी एकेडमिक माहौल है और हम लोग को लगता है कि बिहार झारखंड में ये जो हो रहा है शायद और अदर स्टेट में भी हो रहा होगा, लेकिन हम लोग का बिहार झारखंड का काफी अच्छा है. और हमारे प्रेसिडेंट सर भी बता ही रहे हैं कि हम लोग काफी अच्छा कर रहे हैं. तो और मनोज जो हमारे एक्स जीसी मेंबर हैं, थैंक्स मनोज, ये आप हर जगह हर समय उपस्थित रहते हैं गाइड करने के लिए. वेरी वेरी थैंक्स टू यू. और आज हम देख रहे हैं कि डॉक्टर बीके प्रसाद सर नहीं दिखे, लेकिन वो काफी इंटरेस्ट लेते हैं और हमारे सभी साइंटिफिक सेशन में, सभी सीएमई में रहते हैं. आज किसी कारणवश नहीं होंगे. और डीके सिंह सर बहुत देर से उनकी आवाज में नहीं सुना हूँ. डीके सिंह सर आप हैं कि नहीं हैं?
He left because of an emergency.
अच्छा. डीके सिंह सर से बात हुई थी. वो आज बोले थे कि हम लोग लास्ट में रहेंगे. खैर कोई बात नहीं. तो एवरीबॉडी जिनका भी यहाँ प्रेजेंस रहा है, लगभग मोर देन 50 लोगों का प्रेजेंस था. सब लोगों को थैंक्स कि वो पार्टिसिपेट किए एज ए स्पीकर, एज ए ऑडियंस, एज ए मॉडरेटर्स, एज ए चेयरपर्सन, जैसे भी हो. सब लोगों को हमारे तरफ से थैंक्स और हमारे सोसाइटी की तरफ से थैंक्स. शरद बॉस, और एनीथिंग कि आगे के लिए हम लोग का जो भी हो तो हम लोग डिस्कस कर लें.
One last word, sir, actually, with your permission, Sharad sir.
Yeah, please do that. Please go ahead.
Sir, like our emergency or unanticipated difficult, not every time, we plan and it's fruitful. Like in today's session, we planned everything, we prepared the slides and we did everything. But unfortunately, there was no network. But this applies to our life also. And my thanks for forgetting. I give my special thanks to Nishant Sahai sir for rescuing us in the last minute. This applies to our real life also. So we plan something and at the end of the day, in difficult airway scenario, there is a surprise. Nishant sir, my heartfelt thanks to you. You rocked.
Thank you, Dr. Vamsi. Thank you so much.
So, with this, we come to the end of today's session. I don't see any hand raised. और कोई कुछ बोलना चाहता है तो
हाँ बोलेंगे हम शरद बॉस
हाँ बोलो भाई निशांत पहले बोल ले पहले निशांत को बोल देंगे तो उसके बाद फिर अपने 10 मिनट तुम बोलना
मैं मेरे को सबसे ज्यादा एनकरेजमेंट होता है सर जब मैं वेंकट गिरी सर को देखता हूँ ही इज देयर फॉर द एंटायर टाइम and most CME sir is there encouraging and being present. Just his presence is such an important motivation for people like me that I always feel that people like him, they are the real leaders. They show us how to do what to do. So thank you so much, Venkat Giri sir, and you are still with us, and that is a very big motivation for us.
Thank you.
Exactly. He is always with us. Thank you, sir. हाँ मनोज भाई अब आप क्या कहना चाहते हैं बोलिए.
Thank you very much our chief guest and president ISA National Dr. Venkat Giri sir.
Oh, thank you Manoj. Here we have a long time today.
Sir, actually I am busy in emergency duty.
Okay.
And some bomb blast in Bihar. Hello.
आवाज क्लियर नहीं आ रहा ना.
हेलो
वेंकट गिरी सर आवाज क्लियर नहीं आ रही है सर.
हेलो
यस मनोज जी बोलिए.
Venkat Giri sir, what is the date of SARC conference? Hello. Can you hear me, sir?
सर लगता है कि आवाज उनका नहीं आ रहा है.
Ajay boss, you are looking so smart.
Thank you.
You are giving vote of thanks today in very nice way in our own language. Thank you very much, boss.
Thank you, everyone. So we are going to close the session of the day. I want to thank each and every member of the BJSA for actively participating, especially Dr. Venkat Giri sir for spending the entire evening with the BJSA. We are really privileged to have you, sir. And thanks to Manoj bhai, Ajay ji, Nishan ji, Vamsi, Saurabh, Dr. Lata, Bimlesh sir, Dr. Jagdish Misra, everyone. Thank you, everyone. Have a good night. Thank you very much. Thank you.